Hello, in today's video we are going to discuss about fluid responsiveness. The relation between the preload and the stroke volume is called the Frank-Starling curve. So there is a steep portion of the Frank-Starling curve followed by plateau. If the physiological state of the heart is in the steep portion of the Frank-Starling curve, changes in preload would translate into changes of cardiac output. Therefore, this is a preload responsive or a fluid responsive state. And in this state, fluid administration is likely to give us beneficial effect in terms of increase in cardiac output. If the state of the heart is in the flat portion of the Frank-Starling curve, the changes in preload will not translate into changes in cardiac output. Patient at this stage will not be responding to fluid. In normal clinical scenario, only about 50% of the patients are responsive to fluid, unless the patients are obviously hypovolemic or patients are in the initial phase of resuscitation. In the 50% of the patient where fluids are not going to increase cardiac output, further fluid administration may inadvertently cause harm by causing volume overload, hemodilution. Of late, several evidences have come up linking positive fluid balance to poor outcome. Therefore, unless your patient is in the early phase of resuscitation, has just come in profound shock and you are giving the first 330 milliliter per kg of fluid, or patient has obvious signs of hypovolemia, or there are obvious reasons for you to give fluid like ongoing hemorrhage. For all other patients, you have to check fluid responsiveness and fluid tolerance before administering fluid. The best way of knowing if your patient is fluid responsive is by giving him a small volume of fluid and assessing the response in terms of increase in cardiac output. This procedure is called fluid challenge. To standardize this procedure of fluid challenge, we need to be very certain about the type of fluid that we are going to use, the rate of administration of the fluid, the objective that we are going to measure to estimate fluid responsiveness, and the safety limit which would indicate that the patient is running the risk of fluid overload. Typically, crystalloids are used for fluid challenges unless we have a specific scenario. For example, in ongoing hemorrhages, you may include blood product. Typical rate of administration varies from 250 to 500 milliliters over 10 to 30 minutes. It has not been standardized in any guidelines. The objective should ideally be a real time measure of cardiac output, and a cutoff of around 10 to 15% is usually considered to define fluid responsiveness. If you do not have an invasive cardiac output monitoring, there are certain non-invasive methods that can be used, such as the VTI of left ventricular outflow tract that we can measure by echocardiography. Blood pressure and urine output are not adequate markers of fluid responsiveness. Some other non-invasive methods have been proposed. These are the changes in capillary refill time, the changes in peripheral pulsatility index, and use of bioreactance method of measurement of cardiac output. The limit used is usually central venous pressure, which is a surrogate of the left ventricular filling pressure. So while you are administering fluid, if you see increase in central venous pressure, that means the patient is slowly going towards a state of fluid intolerance, and if we continue inadvertent fluid administration, the patient may end up with fluid overload. For a moderate rise of CVP, say around 2 to 4 centimeter of water, whether you continue fluid challenge or not depends upon your cardiac output response. If the cardiac output response is inadequate, that means it is safer to not continue with fluid administration. If the cardiac output response is very good, then you can continue fluid response, although a bit more carefully. If there is a severe rise in central venous pressure, say more than 5 centimeter water, that indicates that it is safer or it is better to not continue with ongoing fluid challenge. As the methodology of fluid challenge has not been standardized in any guidelines, a systematic review has been done in 2022 which wanted to see the methodology adopted for fluid challenge. What they have found is that the commonest volume of fluid used is 500 ml, the type of fluid is crystalloid, and the commonest rate of administration was 25 milliliter per minute. The commonest cutoff that was used was a cardiac output or cardiac index increase of more than equal to 15%. Now, it may not be possible to administer an entire 500 ml bag to the patient. In that case, we may also employ a mini fluid challenge where we administer 100 ml of crystalloids over 2 minutes and assess for the cardiac output response. So, here the cutoff is 6% increase in cardiac output in contrast with the usual 10 to 15% increase that we take for a standard fluid challenge. The gray zone concept says that instead of taking a single cutoff, we can take a gray zone where the gray zone of 4 to 7% means if the cardiac output increase is less than 4%, it indicates the patient is not fluid responsive, and if it is more than 7%, the patient is likely to be fluid responsive. The cutoff of 6% increase in cardiac output has a sensitivity of 93% and a specificity of 85% in estimating fluid responsiveness. Repeated fluid challenge can also lead to an increased fluid balance and other methods of fluid challenge may be more desirable, because once you administer that fluid, if your patient is oliguric and anuric, it stays inside your body, and there are reversible alternatives to fluid challenge that we are going to explore in our next video.